The brain, a complex mystery organ that influences everything a person does, thinks, or feels. Life after a brain injury can feel just as mysterious and complex, trying to navigate services, experiencing potential isolation, different functioning, and much more. The rehabilitation process can impact the person as well as their supporters. It's often filled with ups, downs, and everything in between, all while the brain is relearning and making new connections within. Join us as the Brain Injury Association of North Carolina sits down with brain injury advocates to discuss a variety of topics surrounding life after brain injury. The more we understand the different aspects of services and effects of brain injury, the better we can help make connections within our community for individuals living with a brain injury. This is Making Connections. Today we're going to talk about headaches, pain, and brain injury.
Hello, thank you for joining us today. We have a really wonderful talk here, talking about headaches and pain after brain injury. And we're here with Alan Finkel with the Carolina Headache Institute. And I'm going to let him tell a little bit more about his background and kind of what his experience is with brain injury and kind of what brings him here today. Alan?
Thanks a lot, Lauren, and welcome to everybody. So I'm Alan Finkel, and I did my training in neurology at UNC. I came from the north, you can tell by my accent. But basically, as neurologists, we did get training in the basics of concussion, head injury, and also relevant to the Brain Injury Association of North Carolina, it includes things like moderate to severe TBI, but most of the work that I've done really has been in the headache domain. And it became quite serious right around the middle of the 2000s, in 2007 and 8, when still at the university in Chapel Hill, I was beginning to see patients coming from Fort Bragg, coming from Camp Lejeune, interacting with the clinicians at these bases. It was clear that there was something that we hadn't seen before. The main injury at the time is very different than a civilian injury, because the main injury and the so-called signature injury of the wars, called the blast injury, which came from improvised explosive devices, and having very little exposure to that, I really began my work by going down volunteering to do clinical work at Fort Bragg at the growing traumatic brain injury clinic. And it was very, very new at the time. It had just been set up in about 2007. So through the course of my work down there, all the way through 2019, we ended up really doing a lot of work studying the kinds of things that soldiers would describe, and then translating that also the experience in my clinic as left UNC. Of most of the injuries that I see nowadays really is personal injury, workers' comp, sports, including youth sports and adult sports, although the presence of so many wonderful head injury centers in North Carolina, including the Gefelder at UNC, really takes up a lot of the work from the NCAA athletes and even some professional athletes with the clinic at Duke and the clinic at UNC for professional athletes. So much of what I do see at this point is adult civilian work. And I continue to follow several of the patients that I saw. I saw hundreds of patients down at Fort Bragg throughout those years. So I learned about post-traumatic headache in a different environment, where the main injuries were blast injuries, and actually even weirder than that, paratrooping, the people who fall out of the sky with their parachutes and sometimes hit the ground pretty hard. Translating that into youth sports, translating that into adult civilian injuries was not difficult because the system that was set up down there was so excellent that I really could learn. And as everyone, I think, knows, who has had head injury, who works with head injury, or who has family members who have had head injuries, especially the concussion injuries, which is the majority of my practice, as I've said, recognize that the clinician, the physician, has only one really important place, and that is to manage the whole spectrum of concussive symptoms. But in fact, we rely incredibly heavily on occupational therapy, physical therapy, neuropsychology, neurooptometry, and again, speech and language pathology, so that most of my work has been as the clinician, but also as a team member. And that is, I think, the most crucial thing that we can come across, is that for the injured soul, the injured person, getting to care quickly is very important, and that's somewhat hard in some of the spaces that we all live in, which would be personal injury and workers' comp, because of difficulty getting to the right person. And also, there are very few of us around the state of North Carolina who are willing to see things like injured parties, whether that's at work or in a personal injury space. So I take to heart the difficulty that people have in negotiating the system and trying to make it a little easier. But I do think that the Brain Injury Association of North Carolina has done tremendous work to educate consumers of medical care, and also clinicians and providers, including those therapists who I've met at several of the BIONC meetings.
Yeah, I think you bring up some really great points just within that. The division of almost like the civilian services and the veteran services. There's a lot of differences in there, but there's a lot that the services can learn from coordinating with each other as well. There's so much that you can kind of convert or translate to other type of services that I think sometimes gets lost. But there's so many resources out there. It's just that communication. And you did mention kind of it being, it's not just a one, as every brain injury and every person is different. There's so many different services that can be available. It's not just one person. It's the occupational therapist. It's the physical therapist. It's a team approach that's really going to make those lasting impacts after a brain injury. And I think that's really great to mention. So as we transition, kind of how can brain injury impact pain? That's kind of what we want to talk about in terms specifically around headaches, pain. What does that look like after a brain injury?
I think you've, Lauren, I think once again, you've kind of hit on the key words. It has to do with the mechanism of injury, and the head and neck are obviously really important. That's where your brain is, and eyes and ears. But also the fact that your head in a concussion space, as opposed to a blunt injury, a penetrating injury, or to brain injury, as opposed to concussion, which is a reversible brain injury, those have many different problems. And it has been said that the more severe the injury, the less headache people have, but it also may be that the other deficits and the other disabilities that people acquire in terms of the cognitive function, motor function. But pain of the head and neck is somewhat special. And the area of my practice, which is also, again, involves a lot of patients with primary headaches like migraine, the first and most important goal of evaluating pain of the head and neck in a patient who has had a mild traumatic brain injury or concussion is first to try to understand what happened. Did they have direct impact? Did they have loss of consciousness? Although that's much less important than we used to think about. Being dazed is enough to call concussion these days. And then what are the patients telling us, and what are people telling us? There's the kind of pain, I break it down into the brain pain and the head pain. The head pain is coming from your head. So if I get hit with a baseball bat right here, and I go to see the doctor 6 months later and I say it hurts right here, we call that, we have some names for that, but it's a site of injury pain, and it can certainly occur anywhere in the body if you think about it. But the head, again, being very special because of all the senses that we have in there. And the head injury may manifest as a headache that's like migraine. And we usually say that about 70 to 80% of the headaches that we see after a concussion resemble migraine in the fact that they associate with light and noise sensitivity. They associate sometimes with dizziness. But you can also have pain of the head from nerves, sharp pains, short pains, electrical pains, things that we know come from nerves of the head or damage to nerves of the head. But when a concussion occurs, what's happening is the brain is going through forces that are being imparted into the brain itself, causing changes in the structure of the brain that then reverse back most of the time when we don't usually see any kinds of imaging changes on things like MRI scans or CT scans in people with concussions. And that's where it becomes really interesting as to what happens with time as headaches evolve, as time passes from the time of injury, because it may end up being that a person ends up with long-term changes in terms of head pain. They can have continuous headaches that can be everywhere. They can have migraine type headaches that come and go. They can even acquire something called migraine aura, which they may not have had before. And that's a visual, psychedelic kind of kaleidoscope, visionary thing that comes and goes away and is followed by a headache in the patients with migraine with aura. But also, when the brain gets rocked, or like my soldier yesterday said, my veteran who said, yeah, we get our bell rung all the time, the changes in the brain may set up headaches that are like other headaches, like migraine headaches, like tension type headaches, or even headaches that we call cluster headaches, which are devastating, extremely severe headaches that are usually just right here. So talking to a person about their headaches, the most important thing that the person can do to explain it to a doctor or a nurse practitioner or a therapist is to just tell them what they're feeling, because light sensitivity is going to be there constantly, but oftentimes with a headache, it becomes very severe, requiring a person to, again, retire into the dark. So when you ask specifically about pain, I talk about headache, but then we talk about neck pain. So many injuries involve movement of the head on the neck, like a whiplash injury, but even a fall to the ground, your head may spin or may flex in different ways. And so many people will have back of the head headaches, like from stretching of the nerves in the back of the head. And sometimes these can be treated with things other than medications, like nerve blocks with lidocaine, or even specialty clinics that use things like steroids against the spine. So the pain that goes above the shoulders in a person with a head injury also, by the way, can associate with other pains around the body. And one very important study from the NCAA actually showed that things like brain fog, sleep changes, balance problems can occur not only with head injury, but with orthopedic injury. So there is something about the pain after injury, but specifically with concussion and more severe traumatic brain injuries, the pains of the head can be devastating and difficult to treat, but we do treat them, and we treat them aggressively with the same therapies that we would use for other headaches, that being migraine headaches or cluster headaches, things like Botox, things like medications, things like pain medicines. We do try to avoid opioids, as everybody knows these days, but an occasional person really may require even an opioid therapy to help them get back to life. And that's the goal of pain treatment and the goal of all treatment for concussion and traumatic brain injury.
Yeah, I think you mentioned a lot of really great things. You mentioned kind of the most, or some of the types of different pains that someone can experience, and different types of headaches. It's not just one type of headache, which I think people might be a little bit not know that, like, maybe all headaches are treated equally, but it sounds like that's not the case, that there are different types of headaches, maybe some more common than others.
That's correct. And if one of the things that we do see with the clinicians specifically and researchers is a tendency to reduce most of the headaches down to migraine, or even to call them migraine, as if there's a beast that lives inside a person that is a migraine and it's liberated by a head injury. But that's really not what's been shown. Migraine occurs in a certain percentage of people in America and around the world. Cluster headache is in a certain percentage of people. Tension headache is very common. Most of us have had tension headache at some point in our lives. and then odd and strange headaches that a specialist will really dissect. And the dissection of the headache and the identification of the type of headache, including those headaches that may come from the neck, so-called cervicogenic headache, the importance is that's how we apply the therapies. So yeah, if I could say one thing over and over again to patients, families, clinicians, therapists, is that be aware that it may not be only just a migraine type of headache, that we might want to dig a little deeper because some of the other headaches respond to different kinds of medicines than migraine might. But it's important to be very aware of the treatment possibilities and not give up. In that same way, I know that many people like things like nutritional supplementation. And again, I think that those can be very helpful. Things like fish oils, coenzyme Q10. Many people are interested in other treatments and procedures. There was a great interest, and still is, even in the civilian world, about hyperbaric oxygen chambers. We have several in North Carolina. The data has not been that great on those, but an occasional individual may get some relief from those. Stimulation devices which are available. At the VA hospital, they use a device that's called a cephaly device, which is a kind of an electrical device that goes on the nerves of the head. There are stimulation devices, all of which are being tested in post-traumatic headache, but have not been FDA approved. And then last of all, most important, I think, is, and the folks at UNC really stress this, that exercise is very difficult for many people because when the heart rate gets elevated, their symptoms may get worse, not just headache, dizziness, vision problems. And so I stress almost immediately the importance of a graded exercise program if a patient is able, understanding that so many adults are not exercising regularly, so that we don't just say, oh, go ahead and do some exercise. We really might use physical therapists or a protocol to grade an exercise program to reduce the symptoms, including pain in the head, because exercise itself may actually repair and treat some of the injuries that occur after a concussion.
Yeah, I think that you mentioned a lot of really great things, just talking about the different types of things that you can do to help either prevent or reduce symptoms for headaches. I know, like you said, exercise is hard for everyone, and it is really interesting to hear that there's kind of a correlation between that and worsening symptoms, but that there are so many different ways that you can like scale back exercising. There's exercise doesn't have to look the same for every single person. So
and the same goes for another one of the most important problems after a head injury, which is the vision changes that people who have them very much understand. Things like screen time. Pacing becomes very important for a worker or a professional who uses the computer. Nowadays, we're all on these computers so much, and the training that goes on in physical therapy and in optometry can be very helpful, but can be very hard for patients because it can make them feel dizzy. And I don't want to, again, forget to mention mindfulness is another thing that I emphasize with my patients who feel willing. And this is easy stuff to get on your cell phone. You can just get a mindfulness app. And again, it's not hippy-dippy. This is really important stuff to quiet the brain, because those connections that are weakened after a head injury can be strengthened by calming the heart rate, by calming the mind. And so even prayer. For those who are spiritually oriented, prayer is a very important form of meditation. And in fact, mindfulness has been called secular meditation because it uses the same techniques to quiet down the body, quiet down the mind, and to allow healing to occur. And in the same way, sleep therapies should be also very much prominent in people's minds, even from the very beginning of an injury. Sleep is one of the things that goes out the window after a traumatic brain injury. And is very important to not necessarily use sleeping pills, although they may be necessary at some point, but to use good sleep hygiene. So overall, we actually call this headache hygiene, exercise, diet, supplements, and sleep. And all of those in combination with non-pharmaceutical things like mindfulness or even exercise, I think can really improve people. And I mean those people who may be distant from an injury a year or two. I would never, ever ask a patient to give up and say that they've had enough. We should always try to emphasize the positive things that we can do with and without medication.
Absolutely. I think it's about, being in the present and trying to that, a lot of times that's what mindfulness and all that is. It's trying to be in the present. And I think sometimes when you're in pain, so, chronic pain, headaches, etc., it's hard to feel anything else but that pain. It's hard to kind of get past that wall of being so uncomfortable. Do you see kind of a difference in headaches over time and how they present from different people? Is there a change, or is there a particular, range that you see?
I think the first and most important thing to tell a person who's been injured in the immediate period is they will get better. Concussions always improve. Symptoms may last for a longer time than people expect. But you're right, there are changes that occur, and I think all of us know this with any pain that we may acquire after an injury, even if it's just falling down and hurting your back. At first, pain is usually very much present, and we have tried to study this, and it's difficult to study, but I assume that all pain is continuous from the beginning, and then it starts to break up. And as it breaks up, then pain freedom, periods of pain freedom can occur, pain-free days. And some people, as time passes, and I mean months and even years, do maintain things like headaches, do maintain things like migraine-type headaches or tension-type headaches. But usually the continuous headaches begin to break up, and a person may end up with a headache that they, again, may need to treat with something like an ibuprofen or a prescription medication for migraine. But also that as time passes, we've also realized that what comes before comes after. So we know that the prevalence of migraine alone in women in America across all ages is 20%. In people in their 20s and 30s, it can rise up to the 30% level. That means 1 in 4 women may have migraine in her blood, in her body, or in the family. Again, about 1 in 10 men, about the same. And so if a person's injured and they've had migraine before, that's probably in the top 5 reasons why people maintain or have persistent headaches. So when you ask about changes with time, I think it's important to recognize that they do change with time. But the longer a person has the pain, the longer it's going to last. And I know that sounds simplistic, but that's really very true. So what we try to do, and I don't think we're good at this, I don't think we're very good at getting to the person very quickly and trying to get them better. I've seen a tremendous change in youth sports, though, and I think that's really important. That locally, we've seen a wonderful network of concussion clinics, mostly out of family practice, that are really helping the youth sports athletes. Again, on the other side, the workers' comp side and personal injury, I see a lot of delays. Many times that's because of the requirements that are for payment of the clinician who's seeing the patient. So that time piece is probably the most important thing that you can ask about, Lauren, because at a certain point, an injured person is going to start to lose heart. They're going to start to lose their spirit. And I think it's really important, again, to emphasize that the 3 pillars that we talked about in military medicine, I think should be applied all across the board: the physical, the emotional and psychological, and the spiritual. And I don't just mean religious spiritual, but I mean that spirituality that gives us the zest that we need to get through days that can be very difficult with chronic pain.
Absolutely. I think those are really, really key in terms of any sort of treatment that someone might have, because headaches really tend to impact everything that a person does. I mean, it's hard to be able to keep a job if you're in constant pain, managing a family. Have you seen that kind of impact that headaches have had on particular individuals, whether veteran or civilian lives?
Again, Lauren, you're spot on. The person who's injured has to deal with all of the issues. And again, a head injury involves the senses as well, so that vision and hearing may be heightened. Bright lights may be difficult. Driving at night can become very difficult for some people after a head injury. But also the other stakeholders. It affects the family. I think some of the most devastating effects of an injury and chronic pain that I've ever seen occur when the individual can no longer be themselves. The woman who's a professional and raising a family now feels unable. The worker who has been supporting his family, who can no longer go to work. The soldier who can't go to duty. The athlete who can no longer play. So the term I use is role function. And the loss of role function does not only affect the person, it affects the entire environment around him, including his or her work environment, and specifically relationships in the family. And I think it's one of the greatest sources of real sorrow and depression that I see when an individual who was not, nobody's prepared for a car wreck. Nobody's prepared to get hit in the head with a baseball at a Durham Bulls game. But it changes your life in an instant. And in that instant, again, many of us were not prepared. We were not raised to know what to do with chronic pain. So the learning process becomes very important. And that's, again, where I believe things like Bianc, things like therapists can be as important as the clinician who's just going to be evaluating the patient for possible concussion and giving medications to try and deal with symptoms.
Yeah, definitely. I wonder, do you see at all, you mentioned kind of the challenges and how hard that could be on someone's mental health. Do you see the invisible nature of headaches? You can't see a headache. You can't really quantify a specific headache as much as you want to try in terms of subjective tests. Do you see that impact a person, throughout their kind of recovery or rehabilitation process?
Absolutely. The fact that a person looks good is often deceptive. People will say, well, you look fine. I don't see your headache. And by the way, as you know, Lauren, the same goes for all those other symptoms that occur after a head injury, the balance problems, the sleep difficulties, the visual problems. A person still may look good, and that is sometimes tricky to make sure that a person understands that most of us don't want to look bad. Most of us are trying to put on our best face for our family, for society, for our jobs. And so the silent nature of headache in a person without a head injury has created an environment in which the stigma associated with pain and headache has been very much on the forefront of advocacy through things like Google groups, Facebook groups, through different organizations. And again, so many of the regional and local brain injury associations are advocates for the patients who are not recognized as having problems because, again, they try to put on their best face. One of the things we also recognize, and not just to focus in on the military, but also on those areas of sports, we know that resilience is something that is not only built into people, but can be shored up and can be trained in. There's definitely a genetic component to resilience, how some people bounce back from incredible adversity and others may really have difficulty coping with some of the changes that occur. So I think that when we talk about the silent injury, we talk about the person who's trying their best to show up and be present, but oftentimes does not succeed. And then we talk about those built-in and those acquired characteristics of resilience, joy, helpfulness, but also being able to admit to those things that you may not be able to do so that you may be able to get the help you need in terms of things like learning, in terms of things like exercise and so
on. We'll be right back.
I was 15 when I was in an accident.
I fell at work. I was a victim of abuse.
Over 200,000 North Carolinians are living with a brain injury. For those living with a brain injury or caring for those who do, the Brain Injury Association of North Carolina is here to offer help, hope, and a voice. We connect you with available providers, support groups, and get the answers you need on your journey after a brain injury. Visit BIANC.net now for more information on our education, support, prevention, and advocacy programs.
When do you think people should seek treatment for headaches? When is it kind of more than just an occasional headache, or, when should they seek treatment?
Well, again, it depends on the nature of the injury, and it depends on the nature of the person and their environment. Again, I think a person who is having symptoms even a day or two later after an injury should probably seek some care just to be evaluated, make sure there's no need for anything like a brain scan. But I would say, practically speaking, through that first month or so, there's been some recent publications that have shown that most people, 80 to maybe 85% of people, will be better within the first month. So doing things like taking some Tylenol, we probably should avoid certain medications in the first few days, only because they can act like blood thinners, things like ibuprofen and naproxen, Aleve is the brand, and aspirin, just for concern that they may be blood thinners and cause problems of bleeding. But I think the person should be evaluated in real time, a person who is not doing well. And in that way, I guess I should mention another important part of the acute period that has been, again, thought about and studied. Many times a parent will, pick up the kid from a soccer game where they had a concussion and will worry about what to do. And the trainer will say, this person should probably go to rest, no screens, no gaming, keep the lights dark, let them rest for a couple of days. But some people recommend it for weeks. And it's now been shown that you really want to start to get back to life as quickly as you can without hurting yourself, without making yourself worse. So in the immediate period, I think symptomatic treatment like rest. There's some people who are using ice on the head in the immediate period after an injury. And there are several devices that are caps, basically, that you can freeze that can be helpful in the immediate period just to calm the headache down. So I think the person should seek care probably after the first week or two if they're really not doing well. But I think the nature of humans is that we are doing really poorly in day 1 or 2. Most people are going to present either to an urgent care or to their primary care doctor to be evaluated and make sure they don't need something like a brain scan.
Yeah, you mentioned we talked about the difference or not difference, but the two different sectors of terms of civilian versus veterans, but you also mentioned kind of children versus adults. Do you see a difference in headaches, how they present, maybe what people report? Is there a difference between children versus adults that you see?
It's a tremendously important area of, there's a tendency to divide the kids into 10 and younger, or even 5 and younger. It depends on which pediatric system you're kind of looking at when we look at the way these headaches are studied in kiddos. But the kids get better, they really do. And there are different ways of dealing with some of the things that go along with the head injury, including things like difficulty learning, difficulty with vision, and then of course headaches. But the adolescents, so those kids 10 to 15, and then those kids 15 and older, again, the ones that I usually see are the youth sports kids, but I know that, kids can fall down the stairs too. The treatments are actually being studied all the way down to 5 years old. And a lot of these studies are migraine therapies or drugs that are given to people with migraine or adults who have migraine type headaches with head injuries. So the differences are not as striking as one might see. I think that the drugs that we're trying to use in adults are also being applied to the kids, But the kids' headaches tend to be a little bit different. And again, when the younger kids below 10, who I don't really see, they do express themselves in different ways. I think as an adult, we have a lot more vocabulary to explain things that we may be experiencing. So that's where the parent becomes a very important observer. And again, the school system becomes an important observers, as do other people who may have to do with return to. We talk about return to learn, return to play, return to duty, return to work, a return to life. And so I think the kids are a little bit more resilient by their nature. And also, I think we may get a little bit more compliance with kiddos because they might enjoy some of the things that we might see. Sorry about that. Some of the things that we might see with the kids who will get into therapies, and they really do enjoy them. I was at a conference recently, it was very interesting, but both for adults and kids. I never thought about this, but one of the things that people experience after a head injury is that when they look at things like in a moving car, when they're looking at the environment around them, or when they're working on a screen, or when they're watching a movie, it may make them feel bad, headachy, dizzy, and that comes from the eyes. And one of the things that they talked about at this conference I went to, and this was through OT and PT, was playing with balloons with kids. Throw them up in the air, let the kid look at the balloon as they're playing with it. Have two dogs out in the backyard. I thought this was really cool. Put the dogs outside and sit there and watch the dogs play, because it allows your mind and your brain to work on your eyes, because that's the difficulty with some of the headaches, again, that occur in people when they're using screens a lot. So again, I said before about pacing, but training your brain can be fun. And the kids seem to have a little bit more fun doing it than the adults.
Yeah, that does sound fun. That sounds a lot more fun than just, random things. Like it sounds like, incorporating things that are fun. Dogs, who doesn't love just like watching a dog live their best life and playing outside, and you can kind of make those therapy chores more, part of life and more fun. That sounds like a good kind of blend of those two, for sure. I did have a question. You mentioned earlier about maybe needing to go to the seek care to get like brain scans or something like that. And so it did make me think about when are headaches considered dangerous? Because sometimes people they have a headache, they get concerned, they go on Google, and all of the terrible potential things pop up, and then we all tend to kind of go over the top, or maybe it just heightens our anxiety a little bit. So when are headaches considered dangerous?
Again, we always say that in the headache space, we call it the first or the worst. A person who has a very severe headache, the worst headache of their lives, we would always worry about whether or not they could have a brain bleed or a hemorrhage. But in a person who's had a head injury, a lot of times, if it associates with, and again, we're talking about in the acute period, Lauren, we're talking about in that first day or two, where a person is experiencing things that are very, very difficult and very scary, loss of vision, real problems with dizziness, real problems with balance, I think that person should be evaluated immediately. So it's not just the headache that drives a person, or should drive a person, to get an acute evaluation in that first day. I think anybody who's had loss of consciousness should probably be evaluated. And a CT scan should be done. So even somebody on the field who gets injured, somebody who says they can't remember what happened, or when the car was hit, somebody who can't remember what happened when they fell and hit their head, if they have loss of consciousness or a period of amnesia where they can't remember things for even a few minutes, they should be evaluated, because bleeding inside the head can be silent. It may not be that it's a headache that worsens because of blood in the head. And there are different kinds of bleeds that can occur in the head, but the one that we would be most concerned with would be the brain itself, or in the coverings of the brain called the subdural hematoma. But the test of choice is a CT scan. And just an aside, but it's an important and interesting idea that recently there was a press release that talked about some testing that could be done to see if a person has a concussion, if their brain has released certain chemicals into the saliva or into the blood that could tell us whether a person has had a concussion. It may lead to imaging, but there was also a very important FDA-approved test that looks at kids. It's not for adults, but looks at kids, and the test may actually predict that a CT scan needs to be done to look for hemorrhage, and it may correlate with hemorrhage. So the testing that's going on, and this is the area that you kind of got me towards, Lauren, is what kind of testing should be done. I believe that early intervention is most important based on the injury and also education from time zero. Tell that person, once you've evaluated them and you feel comfortable, or the clinician feels comfortable, that they've done due diligence to rule out things like a hemorrhage or other issues of brain injury that may be more evident in imaging, to say, you're fine. This is what you should expect. You should expect to have headaches. You should expect to have some balance problems, maybe a little dizziness and nausea, maybe not feeling so well, maybe not sleeping so well, but ultimately those will get better. And even in good studies, it has shown that if we're encouraging in that very early period of somebody with a mild traumatic brain injury, that their improvement will probably be better.
Yeah, so it sounds like being as early as possible, trying to be as, providing that educational component. This is what you should expect, providing those potentially helpful ideas and, small amounts, or, maybe 24 to 48 hours of rest, but then kind of already starting to scale up activity. And, as long as symptoms don't take place, those are kind of always good to get out as early as possible. And I know you mentioned the CT scans. I think some people have trouble because the CT scans are really helpful for diagnosing that kind of emergency bleeding, when headaches are considered dangerous, when there could be that, pressure, that throbbing that could be dangerous. And then some people have, normal CTs, and then people are sometimes discharged not with that particular information because the brain is considered unharmed or anything like that. Do you have any kind of comments on, sometimes those misdiagnoses, or maybe those people that are kind of slipping through the cracks when it comes to a normal CT scan equals a normal brain, when we've seen that's not necessarily the case for mild traumatic brain injury?
That's exactly right, Lauren. The World Health Organization and the CDC in America both have put out statements saying that the expectation in concussion should be that the CT scan or even an MRI scan is normal. And again, for the listener and the learner here, it's important too to recognize that if time is passing, it can be important to get another scan later on, and the scan of choice there would be an MRI scan, looking again for other kinds of complications, not necessarily blood in the head, but you can see some other injuries on MRI scans that you cannot see on CT scans, including small hemorrhages that can occur in concussion, but also changes that can occur because of changes that may relate to pressure in the head. So an MRI scan is not something that a person should move away from if their symptoms persist. And my recommendation is, if a person has persistent symptoms for more than a couple of weeks, and the symptoms are really in the way, then I think an MRI scan is not only important, but it can be reassuring. At the same time, is a little confusing because a normal scan does not mean a normal brain. A normal scan just means a normal scan.
Yeah, I think that's an important distinction for sure. So I think, as we kind of wrap up here, is there any advice that you have specifically for professionals that might be out there that are, looking to support more individuals, more holistically, or help them better with their pain and headaches that they experience?
Yeah, well, again, speaking specifically to clinicians, we should also remember that all clinicians are not doctors. We have wonderful nurse practitioners, PAs, and even people now who are in the so-called mid-level who are really important caregivers. So I think the best advice I can give is, first of all, validate the person's experience. Tell them that you believe them, and make sure that you do believe them. There may be some people who are very shy about giving a lot of personal details, but it sometimes takes time. So what I tell people who are injured is that I want them to trust the system, and sometimes that's difficult because the system may have been rough on them or may not have helped them. And that doesn't just mean somebody who's occupationally injured. It may be that an athlete, for example, is not really loving their sport anymore after they've been injured, but they've been encouraged by trainers and parents and fans to continue the sport that they were injured in. The same goes for any occupation, including in the military. But I think the best advice a clinician can give to a person or a patient is that you are there to help them. And sometimes it's not easy, because taking care of people who have not gotten better for a long time, for weeks and even months, can be frustrating for the person and the patient, but also for the clinician. So I think what I try to teach my residents and students and fellows is, when you're taking care of people with chronic pain of any type, and again, the symptoms that associate with traumatic brain injury, mild, moderate, or severe, can also be not just pain symptoms, but to develop calluses in the right place. Tell the person what they need to know, and don't blame the patient, and certainly don't default to something that you may not know as much about as we may presume, which is the psychology of the patient in front of us. I think it's presumptuous to assume we know the patient's soul or whatever, but to take care of what you're good at, and admit to what you do not know, and then try to find the appropriate therapists who can be helpful. And that's why specifically in the concussion and brain injury area, the team approach becomes so absolutely important, because many times something simple for dizziness, like an Epley maneuver, which I don't even do very well, but a physical therapist can do beautifully, can really get a person out of a period of vertigo or dizziness that may have been triggered, again, by something like a fender bender when they had a head injury a year or two before.
Yeah, that team approach can be so helpful. Believing the person. I know that I come into so many people that are like, thank you for listening to me. Thank you for treating me like a person. I think people have been, unfortunately, in a system where it wasn't built for people with brain injuries, and they've unfortunately felt the brunt of that. And that can get really tiring for a lot of people when they're already in so much pain and experiencing so many different challenges. Do you have specific advice for those individuals living with brain injury, with concussion, their families? What specific advice would you give for them?
That really puts me on the spot, doesn't it? Because again, all I can say is try to make sure that you get what you need, whether those needs can be met in the family, whether those needs require consultation. But as we've discussed, throughout this talk today, it can be difficult to find the right people. There are not a lot of people who do really good work with people in the long term, because these are chronic problems, what we're talking about. In the acute period, I think much of the work that's done is good, and sometimes just good enough. And the people in the ERs seem to know what they're doing. But once you get beyond that, and the primary care person is struggling, I think being proactive is important for the individual. And as I said before, I think remaining positive can be very, very difficult. And a person is not going to change into a different person just because they have a head injury where all of a sudden they say, oh, I forgot. I just need to do exercise all the time, or I just need to eat right. I think a lot of it is going to happen in the society around that person, the school system, the trainers, the doctors, and in the family. but it can be really hard. And I don't want to make it sound easy, Lauren. The people who I see of all different types and all different ways of living, they struggle really hard. And that is something that's difficult. And I don't have the best advice as to what to do other than if professional help is needed for depression and anxiety, if physical therapy is necessary again. But some of the emotional challenges really are difficult. So when you say what's the best advice, I would hate to say it, but waking up in the morning, giving yourself a hug and saying, I got through another day, sometimes is the best advice I can give a person.
Yeah, I think that's really that kind of self care in some sort of way, and just being careful with yourself, and giving yourself reprieve sometimes. Is there any additional kind of information that you want to end us on, something we didn't touch on, or more information about the Carolina Headache Institute that you want to share with others?
The only thing I would want to say to the listener is I think Lauren nailed it before. Sometimes it feels lonely to be the person who's been injured because people don't seem to understand. I think that it's, in closing, this is an area that is thankfully becoming more and more out in the open. Things like what's happening at the NFL, what's happening in the NCAA is a growing awareness, maybe not enough, but a growing awareness that these can have long-term consequences. So I think it's important to make sure that proper evaluations are done, that proper training is done, and also that advocacy work, like the work that the Brain Injury Association of North Carolina does, is absolutely crucial. So for those people who have been injured, but who do want to do something to help others, joining an advocacy community can be very, very important. So helping others can help yourself.
Absolutely. And thank you for coming on today and helping others help others too. So thank you so much. I really appreciate it. And I hope everyone out there has a wonderful day, enjoyed this talk, and learned a little bit about headaches and pain. Thanks so much.
Thank you, Lauren. Have a good day.